Good afternoon. Welcome to the webinar during which we'll be looking at using NICE guidance to improve and evidence quality in adult social care. I'm delighted to welcome two colleagues. Diana?
Hi, I'm Diana Westwood. I'm from the Care Quality Commission. I'm currently Interim Head of Inspection in the North Eastern Coast. I will warn you that I've got a little bit of summer hay fever even though I'm in the middle of London, so any coughing and spluttering is me, please forgive me.
And I'm Pauline Shaw, Director of Care at the Royal Star and Garter Homes. We are a charity that cares for veterans. We have 3 homes, and I'm also a registered nurse.
Hi, and I'm Melanie Weatherly. My day job is as a provider of domiciliary care to adults. Most of those are dependent on the state for their funding. I also have a representative role in a number of care associations, locally and nationally, and I'm delighted to have been started a NICE fellowship in April, which is one of the reasons why I'm here, because the NICE guidelines are very dear to my heart. Before I go any further, I should have said right at the beginning, please ask your questions on the chat function. I can see quite a few people are doing already, but if you do start to talk amongst yourselves, which is great, and want to share email addresses, please remember that they are visible to everyone and they will be recorded, so they could go worldwide. But don't let that stop you. So during the webinar, we're going to firstly go through the NICE products that are available and the kind of things they cover. Then we're going to have a more detailed look at the guidance on dementia and oral health and the opportunities and challenges that they present. And Diana's going to look in more detail about using NICE guidance to address areas of concern and the links between the guidance and the CQC key lines of inquiry. So the NICE aims to improve quality in health and social care through development of guidance based on the best available evidence. And this is a very robust process. So you can be assured that if you find a resource on the NICE guidance, then it's a safe resource to use. And I think that's one of the big benefits of NICE. You can not only steal with pride, but you can steal with confidence. And you'll see later that there are Australian resources in the oral health resources and Scottish toolkits and all kinds of other things like that. But one way to really find out how the evidence is put together is to join in the development process, which Pauline has done.
I have indeed. It was an incredible experience. So I was delighted to be part of the dementia guidelines on the subcommittee for adult social care. And I was also involved in developing the quality standards for dementia with NICE. And I can really advocate this as a very positive experience. I learned a great deal, and it was a wonderful opportunity to see how the guidelines are developed and just how robust the process is.
Thank you. So there are lots and lots of guidance and standards on the NICE website, and a lot of it is really fascinating, but not all of it is directly relevant to the care sector. NICE have very kindly gathered all of that together in one place. This slide and the next slide gives you all the numbers, the reference numbers if you want to go direct to one. But if you go into NICE Adult Social Care, there is a whole page just for us, which actually leads you to all of those. There are 2 main types of product. The guideline is the detailed practice of how to and why and the evidence that's based on. And then for a lot of areas, particularly in social care, there are quality standards which bunch it all together and actually give you a really good way into looking at NICE guidance compared to your own organisation. If you can answer yes to the quality standards, you're in a good place. And they're much easier to read, they're much shorter than the overall guidance, but they don't substitute for reading the overall guidance. Managing medicines is probably the best known within care homes, possibly because we still associate NICE with medication. But many topics that you might not think have been there would be there, so particularly transition between hospital and care home. That's a really interesting guideline to go and have a look at. Quality standards, not just quality standards for the care home, but also for the medical profession. So they can be quite good ways to start conversations with other parts of the system. I've just seen a question asking if the slides will be made available after the webinar. Steve, are we going to be able to do that? Yes, it's being recorded so you can have a look at them later. So you don't need to take any notes of anything we say. Alongside the normal NICE guidance, there is a quality improvement resource which was developed as part of the Quality Matters programme. It's a good place to go go from Chloe to NICE guidance and to start to benchmark your own service against the NICE guidelines, which are best practice. My one caveat would be, don't try to do the whole thing all at once. Pauline's perhaps going to talk to us about how they introduced NICE guidelines and how they use them, but I would suggest that taking the whole of the Chloe and the whole of the NICE guidance possibly isn't the most appropriate way to start.
I think that's right. I think you have to decide which are the priorities for you and then make a decision about what is going on in your organisation and which aspects of the Chloes and which aspects of NICE guidelines are the ones that you really want to focus on. You can't do everything at once. We all think we're superhuman in social care, but actually we do have to prioritise.
And the final thing that we want to draw to your attention are the quick guides, which are the colourful, short, simple summary, which you can share with members of staff and also with relatives, because sometimes NICE guidance can be overwhelming for them as well. And they can, in some cases, particularly the more recent ones, give you an aid memoir as a manager when you're going through your service. We're going to look at oral health in more detail shortly, and the oral health quick guide actually gives you a very good summary of how we thought about this, how we thought about that, which can be used at staff meetings and supervisions or as part of training. But again, they're not a substitute for the main guidance.
And Melanie, you were also saying earlier that if you are trying to advocate on behalf of somebody that you're caring for in your service, they're a really good tool and almost make you feel armed when you go and have those conversations?
Absolutely, and I think they can also arm relatives because they give the relative the expectation in a summary form of what best practice is saying, which can be very reassuring for someone coming into care because we do have some poor experiences.
I think the other thing that's just occurring to me as well is how, as registered nurses, you can use this evidence as part of your revalidation. So with the NMC, to be able to demonstrate that you are up to date, that you are reading the short guides and you are reading the guidelines, that you are absolutely up to date with clinical practice. And I think for revalidation purposes, that's something very useful to bear in mind.
Thank you. There are some other resources that are specific for social care. There is a social care trainers resource. There are a number of webinars and podcasts. And then there is a social care e-bulletin that comes out from NICE every month. If you don't currently get that into your inbox, there's a link on here as to how to sign up for that, and I would definitely think it's worth doing. It's not long, and it's sometimes new things happen, and with the best will in the world, you don't actually notice them. So going to look now at NG97, which is the NICE guidance on dementia, and how useful that could be for registered managers. And this guidance is different from the other one we're going to look at in that it's not specific to people in care homes. It is looking at the assessment and treatment and management of dementia as a condition, so it covers the entire health and care system. And in some ways, we're more of the experts in the room here, possibly than some of our medical colleagues, because the guidance has some very, very strong elements of person-centred care. There is a definition on page 10 of the guidance, which for most social care practitioners will be yes and. But for a lot of our medical colleagues, it's revolutionary. So we need to help them to start to look at people as people, and I think dementia is a good way to do that. And I know Pauline was very heavily involved in putting this together, so perhaps you could tell us how that worked.
Yes, and I think one of the challenges was to have a broad, all-encompassing approach to the guidelines, because it isn't just about dementia care in care homes, it's about people living in the community, and it goes right through the journey from identifying the very early symptoms and signs of dementia and helping and supporting families and significant others in coping and appreciating what is going on with their loved one. And I think to make the guidelines holistic as well, to truly be looking at a very person-centred approach beyond a medical model, meant that there was a lot of debate and a lot of discussion. But I think we've partly got there. There's more work to be done on this, but we have made some really positive headroads into making it more holistic.
Thank you. And I would say that as a manager of a care service, it's really important to know the responsibilities of the rest of the system to support you, to enable you to deliver good quality dementia care. And I've certainly found that if when you're talking to senior clinicians, you can actually refer to the NICE guidance. They understand that, it's speaking their language, they will listen to you. You do have to remember that it is guidance and it cannot overrule the clinician's clinical decision, but maybe whether someone has a 6-weekly review of their medication may not be a clinical decision not to do it. It may just be that we didn't quite prioritise it. And if the care home manager is saying, under the NICE guidance, these people need a review, that's easier for our medical colleagues to pick up. It also looks at workforce and advanced care planning and has some really clear guidance on what that should be. And whilst I'm discussing that, there are some interesting wordings in all of the NICE guidance which are fully understood by our medical colleagues, but which social care are perhaps coming new to. You will see throughout the guidance the words offer and consider. Now, to the normal mortal, there's not much difference between those two, but in NICE guidance, they are very different. If it says that someone should be offered something, then that is saying that all other things being equal, that's the pathway that they would be going down. If it says consider, that's probably, it will be something with less evidence behind it, and it may or may not be the right thing to do. So they are different, and they will have a different conversation. And certainly a lot of the clauses in this guidance say refer, underlined. And that's not an optional referral, that's the expected pathway. Again, clinicians may choose not to in certain circumstances because it's not right for that person, but the normal expectation would be, if it says refer after 6 weeks, then that's what should happen. The other thing that's quite interesting in the dementia guidelines is they have moved some of the treatment pathways away from specialist secondary care into primary care. And I think care home managers will need to support their primary care colleagues to implement those bits. I don't know whether you would agree with that, Polly.
Yeah, I do, and I think it is about joined up working. And what we identified going through the review of the guidelines was that some of the care that is provided is quite fragmented. It might be excellent in its own right, but really people need to be joining hands together because we all have the same ultimate goal, which is to do the very best for the person concerned and their families, because it is a whole family approach. But I agree, better joined up working and communication between all aspects, between all parts of the sector is crucial.
Thank you. So we need system-wide working to implement this policy properly. What we did in my locality in Lincolnshire was we sat round the table, the whole system, with the NICE guidelines sellotaped end-to-end in the middle of the table with a facilitator, and by the end of the afternoon we had a county pathway which each organisation could sign up to their bits of it. And I don't think any of us would have been able to do that on our own, and I don't think the system would have been able to do that without all of us there. So if you're not aware of that joint working in your area, use the guidance to start the conversation. Refer to the number, because that's how NICE normally works, and actually email someone within your clinical commissioning group or ICS, depending on what you've got, and actually say, what are we doing as a system to ensure that this guidance is implemented properly, and can I help? Again, with carers, there's lots and lots of references in the guidance to the need to support carers when family members are living with dementia. And it might be worth asking your local carers first, or carer support groups, are they aware? What are they doing? Because this is definitely a guideline about the whole of the life journey with dementia. And finally, that shared learning. With each of the established guidance, you'll find, if you look on the website, something called shared learning, which is local success stories. There aren't any for the dementia guidance yet, because it's too new, I suggest. But if you do something together, particularly if you're working together and you find a way to overcome professional boundaries, resource issues, or just the fact that you don't normally talk to each other, please share it through NICE so that the rest of us can benefit from what you do. And they also have awards which end up with a very nice ceremony afterwards if you get far enough. So we're just going to show you the different, what the website looks like. There is a guideline which looks like that one, and that you can follow anything through in blue onto the different pages to get more details. This isn't a live shot, it's just a screenshot, so I can't show you how it works. The quality standard, which for dementia you can see there are quite a lot of different quality standards. And the pathway. The more boxes there are on the pathway, the more widespread the guidance and the more complex the subject area. So not all of these boxes will be directly relevant to care providers, because some of them are about the merits of different kinds of pharmacological interventions, which you might be interested in, and it is there, it's not passworded, you don't have to be a doctor to read it, but maybe not that interesting to us. And finally, this is a little bit that's tucked away at the back that quite often we don't look at, and this brings together all of the tools that other people have put together, and also has a very good way to benchmark your service. In the top right hand corner, I think it's very difficult to read, but you'll see it on the screen. There is an Excel spreadsheet where you can look at all of the guidance and benchmark yourself against it. But you might find the way that Deanna's going to explain later is easier. It also has a number of other areas of specialism. Again, with the dementia, because it's very system-wide, some of the resources won't be relevant to care homes, but they do make quite interesting background reading. And if you're caring for 20, 30, 60 people who are all living with dementia, it might be quite good for particularly one of your registered nurses, to really dive into some of that and become an expert. Because I think one of the other things about the way that this guidance has been put together is it actually brings the social care providers into a different space, because it's helping us to look at being part of that process and being partners and equal partners alongside our clinical colleagues. Moving on to the NICE guidance on oral health. This is slightly different. It is specifically aimed at adults in care homes. It's been around since 2016. The quality standards were put together in 2017, but those of you who have read or seen Smiling Matters this morning will not be surprised to hear that it's possibly not been very well implemented. Deanna might be wanting to share some more about that, but I think 39% of providers didn't even know it existed, which is quite worrying.
That's right, and I'll go into that in a little while, but actually that was one of our recommendations. There were too many people living in care homes who were not supported to maintain and improve their oral health, and one of our top recommendations was that care home services need to make awareness and implementation of NICE guideline NG48 a priority. I'll talk a little bit later about how the NICE guidelines informed the thematic review, but very, very important. Thank you.
And actually the quick guide here is probably the easiest and quickest and most effective way to start to do that. It is simple to read. It contains the assessment tool which NICE have suggested as being a good way to start the initial assessment. And so if you do nothing else, if you are one of the 39% who aren't aware of this guidance, I would suggest that downloading and printing that off or getting hold of some hard copies if you can would be a good place to start. Having done that, you can start to benchmark your own service against the support with dental hygiene, the assessment that you do, and the links to local dental services. I think it's not so much about training or anything specific, but I think the problem with oral health is we need to change the culture. We need to remember that the mouth is the key to our well-being. We smile with our mouths, we express displeasure with our mouths, we communicate with our mouths, and our mouth is the first implement that we use to explore our environment when we're very, very young. But I think sometimes as we move into care, it almost becomes the forgotten bit of the body. Whether that's because 10 to 15 years ago, everybody had dentures and they just took them all out and put them in a pot, or not, I'm not sure why, but I think we need to look at the links between oral health, good nutrition, good skin integrity, and general well-being. We all know that if our mouth is not at its best, we're probably not having a good day, and oral pain is excruciating. And if you actually stopped most of your care staff and said, would you do something small that would avoid your service users being in pain, I'm sure that 100% of them, or very close to that, would say, absolutely, yes, I would. But they don't link that with taking that little bit more time to make sure that the teeth are clean, the dentures have not got bits underneath, and most importantly, the dentures still fit.
Annette Brandstatter, you've asked a question about guidelines on oral health for community social care providers. There are guidelines for oral health promotion in the community, which should cover some of that. And there's also oral health promotion for local authorities and providers and partners, sorry. So there is some of the wider oral health guidance in there, not just limited to care homes.
Okay. And I think a lot of the basics, the change in culture is relevant to all care staff. It doesn't matter whether you're supporting people in their own homes, in a community setting, or in a care home. Thinking about the importance of oral health and oral hygiene and the way that that links to life generally, I think matters to everybody. So going back to the guidance, it also can help you to start with discussions with commissioners. I think one of the reasons that this guideline hasn't quite been implemented is that when it came out, care homes were in one part of the system, dental services were in another part of the system. They weren't even commissioned by the same people, and the guideline requires you to work together. And possibly now, as we move into a more integrated world, we might be in a better place to do that. And again, having seen the report, I don't think we have a choice. As care providers, we are going to have to get our system better. So if you've not worked with your local dental committee, they're the same as the local medical committee, but for dentists, look them up, go and get to know them, because they will be struggling with this guideline in the same way that we are, that we want to do it, we don't know how to do it in terms of resource, but we need to work in partnership. Again, there's a guideline. The standard on the dementia care, as I said, was quite long. For oral health, it's really simple, and it's three things that nobody could disagree with, which is that oral health needs to be assessed, and the hygiene needs to be provided well, and people need to be supported. The pathway is not too complicated. And having looked at the two guidelines, Deanna's now going to talk to us about how you actually take that nice guidance into improving your CQC rating.
So Bill, you typed earlier, you raised the question about how do individual inspectors correlate NICE guidance with key lines of inquiry, and I hope that this will answer some of that. But as a clearer answer, when we designed our key lines of inquiry for inspectors, and what we also do is we offer them a series of prompts. These were done with consideration to all the guidelines available, and that would have included the NICE guidelines as well. And when we go on to the oral health, you can see how important that was in terms of our oral health care review. So actually, what we found was that in 19% of our outstanding CQC reports for care homes and services at home since April, 19% of those rated outstanding actually cited NICE guidance, so they were able to demonstrate how they were using that guidance to make a difference. Colette, I will get to your question in a minute because that's a very good question when we get to the oral health section. Sorry, I'm just being having problems scrolling here, but I'll get there. Right, so let's have a look at some CQC examples about putting guidance into practice. And what I did here was I went through some of the NICE guidelines and I looked at how they impacted, if they'd been adhered to, how they were reflected in some of the services we saw. And here's an example from a service that was rated as inadequate. And actually it was found that best practice hadn't been embedded due to a failure to oversee that staff were trained appropriately and applied their training in their roles. Staff did not have the required knowledge to provide people with appropriate catheter care. So this was a service that was supporting people who were living with dementia. And here again you can see how important it is that staff know what guidance is out there, but not only that they're using that guidance, but that providers are overseeing that staff understand and apply the training and they're learning from using that guidance. Whereas in an outstanding service, we saw that assessments of people's needs were holistic, comprehensive, that providers were looking for lots of information and recording this. So lots of information about the people, lots of information about what was out there, and recording this to identify good outcomes for people. And the internal multidisciplinary team discussed the current guidance from NICE, which provided the guidance to improve the health and social care. So here was an example of teams within a service getting together, talking about what the NICE guidance offered and how they could implement it. And this made sure that the service was using evidence-based techniques to support the delivery of high-quality care and support. So earlier on, when Melanie made her introduction, she was talking about stealing with pride, because you know it's research-based, it's evidence-based, and if you're relying on it and using it and implementing it, you can't really go wrong on that. So coming to oral health. So just today, very timely, we published our report, Smiling Matters, and we've already made some reference to that report and the findings. And when we put together the thematic review, we asked two questions, just two questions. And actually, the first question was about how are care homes using the NICE guidance to ensure that they are looking after the oral health care of people in their services. So that's how important the guidance was, that it informed half of our review and half of our evidence gathering. So the report is available on our website. There's been bite-sized snippets, all the ones that are quite exciting have made their way onto the news pages already. So some really strong examples there. But I really would recommend that you use it, and it constantly reinforces the message that actually if you're going to have good oral health care in care homes, you need to be looking at that guidance. So, Colette, you talked about a client who was under DOLS and refuses to go to the dentist and basically just won't go. Well, I have actually come across an example of that, and I'm not sure if I'm going to get to it. In fact, I think I may get to it. So just in case I'm not preempting, because I'll get to your question in a minute. But here's an example of what we found with regard to oral health in an inadequate service. And that was that a person's oral health assessment was undertaken in December 2016 and identified that their dentures were over 5 years old and that the home needed to consider referring the person to the dentist for replacement dentures. They made the same decision in 2017 and twice in 2018, and yet they didn't follow it up. So for 3 years, that person did not have their dentures reviewed, and actually by the time they might have got them reviewed, they were well over 8 years old by then. In a service that was rated as inadequate and ineffective, we saw that the provider's oral health assessment form, pre-assessment form, just had 2 tick box questions. And I've seen this myself. Do they have dentures? And is their mouth sore? Do they have any sores and pains? And that is it. So nothing about their daily health routines, nothing about the products used, nothing about their preferences, and only 2 out of the 4 care records we looked at in relation to dental care included proper oral health assessments.
And when we looked earlier at the quick guide actually includes in it the Australian initial oral health assessment form, which covers all of the areas that best practice recommends that you consider. It may be that you don't have anyone within your service who can make a full use of that assessment form, particularly if you're a residential home without nursing. Doesn't mean that you can ignore that assessment. It means you need to reach out, probably to your dental service, to assist with some training to get people into the situation where they can spot potential problems starting to grow. But you don't need to write or pay for a whole set of assessment processes.
Yeah.
It's already there in that
Yeah.
guidance for you.
Yeah. I'm going to keep going back to Melanie's mantra, still with pride. So actually, yes, I thought I had the answer to your question. The NICE guidance, here's an extract from the NICE guidance, and it is about supporting residents with daily support to meet their mouth care and needs and preferences as set out in their personal care plan after their assessment. So those assessments that I referred to earlier, which were so basic, even if you were to ask them to meet their needs and preferences in with regard to the care plan, that wouldn't have been enough because the care plan didn't go far enough. Ensure that care staff know how to recognise and respond to changes in a resident's mouth care needs. Melanie, we were chatting earlier and you were talking about the colour of a person's gums and staff knowing people well enough to identify that, and you're nodding, Paula?
I am, because I think it is the care staff who know the residents best of all. So whilst clinically they may not have had as robust a training as a registered nurse, they are the people frontline contact, and they do really need to be aware of what a healthy mouth looks like, and that is part of the training, and it is also part of the guidelines. I was just thinking about Colette's question as well, about somebody with dolls, who's under a dolls, and obviously we still can't coerce somebody into going to the dentist or undertaking mouth care, and it just made me think of the experience that we have in our care homes where if a resident is declining to brush their teeth even, that our care staff do carry around with them in little activity aprons their own toothbrush and toothpaste, and they will model the behaviour of cleaning teeth at night. And it doesn't always work, because obviously this isn't going to appeal to everybody, but you know, let's do this together is what they will often say to somebody who is declining. Now, I'm not suggesting for a moment it's that simple and that we could say to somebody, right, we're going to the dentist, let's do it together, and they're going to automatically say, of course, I'd love to go. But it's looking at different methods, looking at different creative ways, looking perhaps at a person who that individual has a particular positive relationship with, seeing if they can appeal to them, and to not talk about the trip out directly, but to use different language and to be really, really creative is something that works for us.
And I think it's also about staff not transferring their own anxiety about dental visits, because I don't suppose it's anybody's favourite place to go.
Yeah.
But if someone is under a dolls and is really in need of dental care, if you read the guidance, there is an expectation that there will be some level of home visiting dental service. That, unfortunately, that's one of the parts of the system that is particularly stressed at the moment. But if the care home is taking all of the people who will go to the dentist, then maybe it's easier for that dentist to come in to see the person who really needs them. And again, that's about working in partnership. And I would suggest maybe you go somewhere on the way to or from the dentist, because that's certainly how most of us work with our children or ourselves. If I go to the dentist, then I will treat myself to something on the way home, preferably not with sugar in it. But actually just to sort of corral people to the dentist and then take them straight home probably isn't going to work.
Or there was this example in this outstanding service where staff were aware of people's anxieties and they were able to work in a collaborative way to make sure that people received support from medical professionals. Now, I'm telling you this, but I do understand that, and we had a conversation about this before the webinar, how difficult it is sometimes to get that professional intervention in terms of your own local commissioning arrangements. But in this example, it worked very well because the person had anxiety regarding dental care, and they had a discussion with staff and the dentist prior to the visit, and then the dentist visited the service, but they had notified the dentist of the person's anxieties. The dentist brought minimal equipment and was able to sit and chat with the person and build trust before any relationship, to build a relationship before any examination could take place. So lots of people, I think, are trying to offer you some support here, Colette. I can see some answers coming through. So keep it. We know that everybody's different, and as Paula said, you know your person best. You know what their triggers are. You know what their comfort zones are. So try and work with those which staff understand them best. Try modelling behaviour so that they might be willing to try managing their own oral health care if they are physically able. So lots of things to try, but we all agree at the panel, and again we were having that discussion beforehand, that you know people so well, because very often in care homes you are the mother, the father, the brother, the sister, because they don't often see their own. You're family to those people and you know them best, and if you focus on a really person-centered approach, that's how you're going to get the best results. So I'll move on and we'll look at a similar example with services for people who are living with dementia. Again, looking at the inadequates, where people could have used some nice guidance, and if they had, they possibly wouldn't have found themselves in these situations. So under the key question effective, we had a provider who'd supported older people, many of whom were living with dementia, and research continues to be undertaken to develop best practice. But during this inspection, we did not find any guidance had been followed either in the home. So what they'd done was they built an extension onto the home, but they'd not considered any of the best guidance practice or within the main body of the home. So these are people trying to change things in a service for people with living with dementia, but they're not considering the guidance about how that might work best. And as a result, it impacted widely on the service, and overall they were regarded as inadequate under this key question. We found a person's authorization that stated that staff should consult with the GP and mental health team regarding risks and benefits of the use of antipsychotic medicines. And the condition stated that this consultation should be included in their care plan. And we saw from the registered manager that some consultation had occurred with the GP, but they couldn't show us any evidence that it had been discussed with the mental health team as per the condition. Again, the guidance for the NICE guidance for people living with dementia will talk about those pathways, will talk about involving the right professionals. And if they'd followed that guidance, and it goes back to Melanie's example earlier about actually sitting all the system partners together, sitting them all down together and working through each person's contribution to that person's pathway. And Bill, again, earlier on you raised the question about that county-wide experience and how they can learn from colleagues in Lincolnshire. And I would also recommend you look at CQC's Beyond Barriers report, because that's something we focused on, is that pathway of care and how partners can work together across the system for a person on their pathway of care. I said it already, you are the people who represent people experiencing, living through these pathways of care. You're very often, as providers, the people who need to negotiate those barriers and those professional boundaries. And if you can persuade people to work together using the NICE guidance, using the recommendations from Beyond Barriers, it should help you and it should help people living in your services.
We can see lots of questions about the dentist. We'll come back to how to engage with your dental community towards the end of the session. So hold those questions and we'll pick that up again later, because I do have one or two suggestions.
And it's clearly a very hot topic. It's
yes.
very good to see all the advice and all the questions flowing. So let's go carrying on with dementia, because we'll get back to oral health care. So if we look at the NICE guidance extracts, again, it goes back to what I was saying, that partners should support people to participate fully in tasks and activities by ensuring that the environment is conducive to their needs. So again, when you're looking at the previous example where they built an extension but not considered people's needs, not spoken to the right professionals, if they had followed this guidance, they wouldn't have found themselves in that situation. The same with access to equipment that people need, same scenario, and considering a range of approaches to gather views and experience. So think about using focus groups, interviews. Don't just rely on your annual survey to families. Actually, how can you really get the best out of people? I have just seen a report that is going to be published where an outstanding provider has co-production with family members, involving them in how they develop their service. And again, this fits in neatly with the NICE guidance. So here's an outstanding service, and when they refurbish the home, particular attention had been paid to the needs of people living with dementia. Toilet doors had been painted in dementia-friendly colours. Each corridor had a distinct theme to make it easier for people to orientate themselves within the home and to stimulate memory. And the people who lived in the home had been involved in every aspect of refurbishment. Did you want to add anything?
Yes, I have some experience in this area, because we moved from one care home to another. We moved 42 people 5 years ago, which meant individuals living with dementia were moving into a brand new building and a brand new environment. And one of the ways we supported them was to work with their families, work with them in partnership, but also develop mood boards and boards which had examples of the colour of their rooms. It had samples of the fabrics that we were going to use. It showed pictures to illustrate what the room would look like, and people had a choice. So we offered a choice of 6 different colours from a spectrum, which were fitted into that environment by an interior designer. And the colours chosen were dementia-friendly colours, and the fabrics from the curtain to the carpet were such that they wouldn't cause people distress. So we did quite a lot of research. We went to talk to Bradford and went to Stirling University as well to get their evidence on this. And I think just being able to engage with people and enable them to feel really involved made a huge difference. And because we were reassuring families, that also reassured the person themselves.
It's a lovely example. So Melanie's already covered this to some extent, but just to let you know that you can also access the NICE guidance through the website. So there you can see how the NICE guidance is mapped to our key lines of inquiry. If you go to the CQC website, there are a lot of documents and guides in terms of supporting you with some of these aspects of people's care, but it will also directly link you to that map so that you can look at the key lines of inquiry and you can select the appropriate NICE guidance that you want to refer to. So I'm just whizzing my mouse again because I can't do it at a funny angle which I'm sitting at, and we're there. No, we're not. Right, I'm going to head back to Melanie now.
There's a couple of questions on oral health around specialist dentistry and whether dentists have dementia training. And I think that takes me back to saying that this guidance, although it's about adults living in care homes, it isn't just doesn't just have things for care homes to do. It has things for our dental providers to do and our commissioners. Dentistry is usually covered by public health rather than the CCG or the local authority. But within the NHS, it's actually organised by region, and your regional dental group will be very keen to talk to you. I go to ours about twice a year because most of it is quite horrendous things to sit through, and I sit there thinking, when did I last clean my teeth? But they're very welcoming. No, they're not always trained in dementia, but they're very keen to be able to support their own patients who are living with dementia. And I'm just sitting here wondering, maybe we could do a swapsy. Maybe the care providers could help the dentist to be more aware of dementia, and the dentist could be helping the care staff to be more aware of early signs of really difficult dental conditions. And certainly the ones I've worked with are very keen to do that. There aren't enough specialist dentists to support vulnerable adults in the system, in the same way that there aren't enough registered nurses. But we have to work together to make sure that we're using those resources in the best possible way. And I think our dentist colleagues will be more than happy to do that, particularly if you frame the question in terms of this guidance or the Smiling Matters report. There are specialist dentists, as Lucy's explained, there are dentists who are trained to support vulnerable adults up and down the country, but they are very, very scarce on the ground. But maybe if we work together and perhaps care homes do a little bit more for the people who don't need the most specialist input, maybe that then means that the specialists can be there to support us. I absolutely think it's got to be about working together, because otherwise we'll get nowhere. And if anybody comes up with some really good ways to do that, please share. As I say, I found that going to our dental service worked well for us, and they actually gave us, through SCIE, Health Education England, some funding to set up what we've called Sona ambassadors, which is swallowing, oral health and nutrition ambassadors. Our dietitians, our dental hygienists come and train 1 or 2 members of staff from each care home to go out and be, we call them ambassadors because we felt that champions had a bit of a, in some places, a bit of a negative connotation. They're not the dental lead, they're not oral health experts, but they understand how to do things. And one of the key things that one of our dental hygienists said is, if someone really doesn't like having their teeth cleaned and you can only do 1/4 of the mouth, have a way of recording in your care plans which quarter, because otherwise they will have 25% of their teeth absolutely sparkling and healthy, and the other 75% will be dirty, because we will all instinctively go to the top right-hand corner first. And that was so simple, but made such a difference. And she also said, and actually, if 1/4 every tooth cleaning session works fine, that means that every 2 days they've cleaned the whole mouth, and that's probably okay for most people.
And just a further thought on dentists. I mean, it is such an invasive procedure for many people, isn't it? And as
Yes.
you say, none of us particularly like going to the dentist. Imagine living with dementia and wondering why somebody's coming at you and asking you to open your mouth. I just wondered whether if more dentists could become dementia friends, which I appreciate is a very early entry level awareness into the various aspects of dementia, but it might support and help them. But also when residents who are living in care facilities go to the dentist, whether a member of staff could go along so that they could demonstrate how they speak to that person and how to support them, because as we've said before, staff really do understand the needs of the residents who are living with dementia and are best able to say, actually, if you do it like this, it works much better for that individual.
I think I agree with you, Pauline. I think now with the CQC report is a good time to be talking to commissioners about care staff will be happy to go along, people will be happy to use their minibus to take people to dentists, but there does need to be some recognition that that isn't a free service, but it's a lot cheaper than taking a specialist dental practitioner to a care home. And I think as care providers, we need to make those points. We need to say it's not that we don't want to, we absolutely do want to, but we have to pay, the staff have to be paid to do that. But also I think when dentists are refurbishing, they may be interested in what works for people with dementia, because if it keeps people with dementia calm, it would probably not be a bad colour for the rest of us to have their surgery.
That's true.
And simple things like don't have all the stuff on show when you walk in. But actually, I'd be happy if my dentist didn't have the drill really obviously in place when I walk through the door. And as far as I know, I don't have dementia.
And just a final thing to add to that is, in our Smiling Matters report for CQC, we have actually made a recommendation to NHS England that it reviews the domiciliary dental care pathway and how it is provided to vulnerable groups. So we've said, while it's generally understood that better care and treatment can be provided in a clinical setting, there is a need for dental care in people's own homes, including when that is in a care home, and it highlights some of what you've raised in your questions, that people might find it too stressful if they're living with advanced dementia, and of course other conditions as well, and that domiciliary dental care should be targeted to those who would benefit the most, rather than just being a universal provision for all, because we understand that that can't happen. But let's identify who our vulnerable people are and see if we can't get the dentist to them.
Bill makes a really good point. There is a major role for members of residents' families in this respect, and maybe our role in that is to use this guidance to actually say, this is really, really important, and this is something that you can do to support us, to support your family members, because I think quite often we don't think about it. We don't tap into the family. If you're a distant family, it may well be that you're happy to provide toothbrushes, really nice toothpaste, but simple things like, what brand of toothpaste did you use at home? Because if you always used one and the care home gives you another one, it's a barrier that doesn't need to be there. So I think, yes, it's about, as Bill says rightly, it's about co-production and listening to the resident and their family, particularly if they present to services with quite advanced dementia, that the person isn't going to be able to tell you what their oral health hygiene was, but their family probably are. So let's talk to them, let's ask them. Let's not assume that everybody did their oral hygiene in the same way. We're coming up to 8 minutes to 2 now, but we've got quite a few comments on dentists. I don't know whether we've got any questions in there or not. Yes, I think, again, about families, I think it's about having a joined up support. Families, care staff, dentists, commissioners. It's really important to people, and it needs to be about a joined up process. What we don't want to have is everybody saying, it's your fault, no, it's your fault, no, it's your fault. So I think it's really good that we can have I think the timing of this webinar is really good, because we can have a positive response to Smiling Matters, which could have become quite a difficult conversation.
Yes, very good timing.
On the final slide, we've got the links, which I understand if you click on them, you get straight through. When you look at the slides, you go straight through to all of the different areas we talked about. Does anybody have any final questions before we close and give you a few minutes to finish your lunch hour? Pauline, do you have any final comments?
Just to reiterate that this is a fundamental aspect of care, oral hygiene, and I think it's quite a damning indictment that we read this report and see the statistics of oral hygiene that is being ignored. And I wonder if it's because people are quite able to keep their mouths closed and we don't look inside. And I think this whole aspect of being really vigilant about the holistic care of each individual means that we do look inside. We do ask the families and we do work together to support people. We've got to get it right, haven't we?
Yes, and I think this is a very good way where we can use the NICE guidelines to improve quality and to look for best practice. And I'm hoping that from this, it's not just about this is just good enough, but actually this is what I would want for me and my loved ones. And I think it's got the evidence base, so you don't have to go out and do all of your own research. You can absolutely take what's on there and say, yes, we're going to try this. Any final thoughts, Diana?
No closing points from me other than to say, yes, keep checking the guidance, keep checking the website. We've done oral health. Well, I'm sure there'll be another thematic review soon, and if you've read your nice guidance, you'll probably be ready for it.
Okay. Thank you very much, everyone.
Thank you.